Good morning and welcome everyone for the morning screening sessions. And now I would like to invite Dr. Rajiv Pandey sir on the dais.
डॉक्टर्स प्रेयर के लिए कृपया खड़े हों। सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुर्भाग् भवेत्, न त्वहं कामये राज्यं, न स्वर्गं न पुनर्भवं, कामये दुःखताप्तानां प्राणिनाम आर्तनाशनम.
Good morning everyone. Very warm welcome to this fifth morning CME of GP Association. So today's CME is basically focused on highly relevant and commonly encountered medical issue, acid peptic disorder and gastro-esophageal reflux disease. These conditions affect a significant portion of the population, and recognizing the red flags associated with them is crucial for effective management. Acid peptic disorder and Gerd are not only frequent clinical complaints but can also lead to serious complications if not properly managed. Gerd in particular can disrupt daily life for many patients, causing everything from mild discomfort to severe esophageal damage. Recognizing the warning signs and understanding how to treat these disorders is vital for improving patients' outcome and reducing the risk of long-term complications like esophagitis, strictures, and even esophageal cancer. So today's session will provide us with valuable insights into the red flags, diagnostics, and management strategies for both acid peptic disorder and Gerd. And today we are privileged to have him share his insight with us. Let's give him a warm round of applause as we welcome Dr. Rishabh Gupta to enlighten us on this crucial subject, acid peptic disorder and Gerd, red flags and management. Please.
Good morning, everyone. Dear and respected seniors. I am privileged to be part of GP Association, which is about to complete its 50 years. And my topic of today is acid peptic disorders and GERD, which we see day in and day out in our OPDs. So the management and algorithm is similar to any other disease we see. We first look for the symptoms and signs. We try to fit it in symptom complex, that is a syndrome. We rule out mimickers and alarm symptoms that could be grave if we miss. We make a clinical diagnosis. We can or cannot confirm the diagnosis. We can even start an empirical therapy. We treat the disease, assess the response, prevent the complications of disease and side effects of therapy, and at last there is long-term surveillance or cancer surveillance if it is a risk of cancer. So acid peptic spectrum consists of three diseases basically. The first one is peptic ulcer disease. The second is functional dyspepsia or non-erosive dyspepsia. The third is GERD, that can be either erosive esophagitis or non-erosive esophagitis. The other terms we commonly use in a clinical practice is gastritis or gastropathy. But since the term gastritis is an histopathological term, since it contains itis, that is inflammation of gastric mucosa. And the term gastropathy is limited to endoscopic terminology. If we find any findings on endoscopy, it is termed as gastropathy. So the classic symptoms of acid peptic disorders include epigastric pain, occasionally that can be either right or left upper quadrant, postprandial fullness, early satiety and nausea, indigestion, retrosternal pain or chest pain, heartburn or regurgitation. These are all the symptoms we see in OPDs. And we try to fit in complex. The two complexes are dyspepsia and gastro-esophageal reflux. The classical features of dyspepsia are epigastric pain, postprandial fullness, early satiety and indigestion. And if we see chest pain, retrosternal pain, heartburn, regurgitation, and any of the laryngeal extraesophageal symptoms, the syndrome is gastro-esophageal reflux syndrome. Though in our OPDs, the patient may only complain of gas, and gas can mean a lot of things to a lot of people. It can mean dyspepsia, heartburn, belching, bloating, colicky pain. Even some patients with colicky pain and obstruction complains of gas, constipation, chest pain, and now even patients have headache, body ache and anxiety that they complain of as gas. So we need to make a syndromic diagnosis out of these symptoms. So first is GER or GERD, gastro-esophageal reflux. Gastro-esophageal reflux is a physiological phenomena that occurs postprandially normally, and it is usually short-lived, asymptomatic, and does not affect the mucosa of the esophagus. And it is due to the transient relaxation of lower esophageal sphincter, that is to vent out the excessive gas in our stomach. And when is this physiological GER or GERD? And we need to define that. The reflux of gastric contents in the esophagus resulting in symptoms and or complications. The keywords are symptoms and complications. It occurs due to prolonged exposure of esophageal squamous mucosa to acidic secretions of the stomach. So this is the clinical definition, but we need to define it objectively, and for that we need to we can do two investigations, endoscopy or a reflux study. If there is any mucosal injury which may or may not be there in GERD, it is defined as GERD, and if the endoscopy is normal, we can go ahead and do an acid exposure time of lower esophagus, that is in pH study, to confirm the diagnosis of GERD. So this is the this is stomach, and this is the gastric content that can reflux into the esophagus. And the normal phenomena in physiological refluxes are normal esophageal clearance. The peristalsis of the esophagus normally clears out the residual content of the esophagus back into the stomach, and resistance of esophageal mucosa. And the main is LES. The main physiology against GERD is LES, and the competence of LES is maintained by the His angle, tone of the LES, and diaphragm and the diaphragm. And if it is altered, that is if there is an hiatal hernia, there is an increased transient relaxation, it can lead to GERD. Now coming to the symptoms can be classified into classic symptoms and non-classic symptoms. The classic symptoms that we need to remember very important is heartburn and regurgitation. Any substernal burning from epigastrium towards the neck is called heartburn, and regurgitation is effortless return of gastric content towards the mouth associated with bitter taste, and it should be differentiated from rumination, that is an effortful regurgitation of contents from the stomach towards the mouth. The non-classical symptom is chest pain, and other non-classical symptoms can present is epigastric pain and bloating, that are not classical features of this finding but of dyspepsia. The extra esophageal symptoms includes hoarseness of voice, throat clearing, chronic cough, laryngitis, pharyngitis, even chronic cough, and asthma exacerbation. And even a patient with non-seasonal asthma should be worked out for GERD, since it can present like that. And GERD is not just about symptoms. The GERD can cause grave complications. It can cause peptic stricture, that is stricture at lower end of esophagus, metaplasia, that is Barrett esophagus, dysplasia, which is a precancerous lesion, and malignancy later on after 10 to 15 years, that is predominantly adenocarcinoma rather than squamous cell carcinoma that occurs in upper 2/3 of the esophagus. So the target of therapy of GERD is symptomatic relief, healing of the mucosa and maintenance of healing, preventing metaplasia and dysplasia, and if it has already occurred, we should try to reverse metaplasia and stopping progression, though there are no clear evidence that we can do that, and removing dysplastic mucosa if that is present, and preventing malignancy. So coming to the how do we diagnose GERD? There is no gold standard test to diagnose GERD. So the diagnosis is made clinically and by investigations, which is composite. We see classical symptoms, we can do endoscopy, and if it is normal, we can do reflex monitoring. And the most common diagnosis that we use in our clinical practice is response to therapeutic intervention, and even clinical guidelines support that. We would see that later. Though the reference standard is endoscopy and pH monitoring, and even the sensitivity and specificity of that is 78 and 54%. Now coming to this is the most important part, GERD mimickers, and we should always be cautious about that. The most common GERD mimickers are cardiac symptoms, and we should suspect that if the patient has cardiac risk factors, the presentation is acute, the presentation is non-classical, that is the classical presentation is retrosternal burning and regurgitation, but in cardiac patients these are not the usual presentation, it is retrosternal chest pain, and if there are features of CHF. Esophageal motility disorder, the most common of which is achalasia. In this, the most common classical feature is dysphagia, and retrosternal burning could be there in patients of achalasia. The third is eosinophilic esophagitis. This should be ruled out in a patient who is young, has history of atopy, has history of asthma, and more or less there would be a history of dysphagia that would be not very severe, but it can present as mimic of GERD. Pill esophagitis, if there is history of recent drug intake, predominantly doxycycline is most common infection drug that we see, and Valgan cyclovir. patients with candidiasis can also present as GERD. If there is history of inhaler intake, the patient is diabetic, immunosuppressed, and patients with complaints of dysphagia along with retrosternal pain or regurgitation, candidiasis could be a possibility. The other disorders are rumination disorder, which is a functional eating disorder which is seen in young female usually, in which the patient has a behavioral disorder in which she uses the stomach pressure to regurgitate the stomach content into the esophagus and out of the mouth. Functional heartburn, dyspepsia in IBS, and peptic ulcer disease. So how can we rule out mimickers? The first is ECG. That can be done, there is a simple test that can rule out cardiac disease. If there is history of atopy, we should rule out eosinophilic esophagitis. That should be done with endoscopy plus biopsy. That can be even blind. If we do not see features of eosinophilic esophagitis on endoscopy, we should take blind biopsies for eosinophilic esophagitis if it is highly suspicious. Endoscopy for pill esophagitis, candida, viral esophagitis. Manometry can be done for achalasia, and manometry can also rule out rumination disorder. And gastroparesis can be ruled out by gastric emptying study. So once we make a clinical diagnosis of GERD, what should we do next? So since it's mentioned, it is according to the guidelines ACG 2022. We should make a clinical diagnosis, and even after clinical diagnosis, we do not need to do any upper GI or reflux study. We can straight away start with empirical therapy with anti-secretory agent along with dietary and lifestyle medications. The anti-secretory agents are PPI, H2 receptor blockers, and PCAB that we would see later, that are now available in Indian market. So the guidelines mention to start empirical therapy, but when we need to investigate and confirm even before starting empirical therapy, that is early endoscopy. If there are non-classical symptoms, or if there are any alarm findings which could even be mild, such as dysphagia, GI bleed, anemia, or vomiting, we do not start empirical therapy and we do endoscopy in these patients. Or even in extra laryngeal symptoms such as laryngitis, atopic asthma, we do not straight away start empirical therapy. We need to do further investigations. So coming to the standard dose PPI, which we start initially. The FDA approved, these are the FDA approved PPIs. The standard dosing is dexlansoprazole 30, esomeprazole 20, lansoprazole 15, omeprazole 20, pantoprazole 40, and rabeprazole 20. Though in Indian guidelines, the dose of lansoprazole standard dose is 30 milligrams. Now, do we need to counsel? We need to counsel all the patients on PPI. It is very important to take PPI 30 to 60 minutes prior to food intake. And we need to check out any drug-to-drug interactions if present, and we need to check any drug history before starting PPI. Patient should explain the benefits, explain that she need not discontinue PPI due to adverse events that they could read on the web or surf here and there, and since the benefits outweigh the risk of adverse events of PPI. Double dose PPI, if given, the patient should take it before breakfast and before dinner rather than in morning and evening. Now, we should never miss to add on diet and lifestyle modifications to our patients of GERD. This is according to the ACG guideline, and some of them are recommendable, and some of them have scientific evidence, some of them not. But we can start all of them. We should avoid fatty meals, avoid carbonated beverages. We should select decaffeinated beverages. The evidence though is not there. We should avoid citrus fruits. We should eat smaller amounts. That would increase, if we eat large amount, that would increase intra-abdominal pressure, and that would increase GERD. We should lose weight, avoid alcoholic beverages, but here again it is not generally recommended to avoid alcoholic beverages for GERD. We should stop smoking, avoid alcohol, exercise, sleep with head elevated, sleep on the left side. Now, the most important is effect of weight loss. In a population-based study in Norway, assessed that weight and GERD symptoms at baseline and 10 years later, and identified a dose-dependent improvement in GERD. That is, if we decrease weight, the GERD symptoms decreases proportionately to that. So we have started the patients on empirical therapy of PPI. We should give at least a 4 week of PPI before starting next or before doing anything else, and it can be given for 4 to 8 weeks. And along with that, lifestyle and weight management should be there. And the situation one would be, we would have an adequate symptom response. What would we do now? we can do two things. We can stop the patient on PPI, and we could see for response. And if their symptoms recur, we could start the patient on lowest effective dose that can be continued for a long term. The situation 2, in which the 4 to 8 weeks of standard dose, single dose PPI is not working, and we should assess them further. So we should now investigate what could be the cause of this not responsive of PPI. It could be that PPI is not being taken properly. We should check the compliance. There is suboptimal acid suppression with PPI. There could be any drug-drug interaction that is decreasing the concentration of PPI, and sometimes the GERD symptoms is not due to acid, and it's not all about the acid in symptoms of GERD. So should we switch to another PPI if suppose the patient is taking pantoprazole? Should we shift him to esomeprazole or rabeprazole? In the guidelines, it is said that it may be considered. Few trials suggest that it is as equivalent as changing the patient to double dose PPI. And the rationale for this is it can be due to variations in metabolism of the PPI enzymes by every different individual. And it can also be considered in view of select side effect profile, that is some PPI is supposed to cause diarrhea, such as esomeprazole. More than one switch to another PPI cannot be supported and should not be done in any ways. So this is again the rationale for switching PPI. It could be due to difference in CYP2, C9 metabolism. And here we can see rabeprazole is the only drug rabeprazole is the least drug that is affected by these hepatic metabolisms. And in patients, if there is a risk of, if the patient is taking many drugs, the drug of choice is rabeprazole, which has no interactions at all, almost. Now, after switching to the first we have discussed is empirical therapy. After that, switching to another PPI, and the third we can do is we can switch the patient to double dose PPI, and the twice, and again a trial can be given for 8 weeks. The dosing should be before breakfast and before dinner, 30 to 60 minutes before. And it is said that it has been seen that it has better 24-hour gastric pH control. And along with that, since it is taking before dinner, we would have a long duration of night. And if the patient has nocturnal breakthrough symptoms, we can add an ranitidine, or that is H2 receptor blocker, along with that for symptomatic relief, not for ulcer healing. And now the third step is the double dose PPI is not working. What should we do next? Now this is the condition when we call this GERD as refractory GERD, that is unresponsive to double dose of PPI for 8 weeks. Now the thing we can do is now this is the time then when we need to confirm the diagnosis of GERD, since we have started the patient on PPI therapy empirically. It can be done by upper GI or reflex testing. The upper GI should be done when the patient is off PPI for more than 7 days, and during this period of 7 days we can give antacids and alginates, sucralfate, for symptomatic relief of the patients, since the patient would be symptomatic. And the second, and if it is normal, the patient can be done reflux testing, that we would discuss later. Now suppose we first did an upper GI endoscopy of that patient. If we do not see any findings of the patient, this does not rule out GERD. The patient can still be a patient of GERD, that is non-erosive GERD. But if there is esophagitis, then the diagnosis of GERD is almost confirmatory, and we can grade the patients of GERD on endoscopy according to Los Angeles classification that we would see in the endoscopy reports. In this, the mucosal tears are less. It is involving more than 2 folds. It is involving more than 75% of circumference, and it is circumferential. And these pictures look very scary, and these can even present with hematemesis, severe hematemesis, and anemia. Now coming to upper GI diagnosis according to the endoscopy, LA grade 1 is not specific for GERD. Non-erosive could be there, in which we would not find any finding. Even with LA grade 1, we cannot label the patient as GERD. But if the patient has LA grade B esophagitis with classical symptoms, it is GERD. And for LAC and LAD, even if asymptomatic patients we find these findings in routine endoscopy, we should label the patient as GERD even he does not have symptoms, and we should start him on PPI therapy. And if we found Barrett esophagus more than 3 centimeters with metaplasia and biopsy, it is labeled as GERD. Along with the benefits of endoscopy is apart from diagnosing, we can also look for complications of GERD. That is, we can look for Barrett esophagus, and it would require a surveillance, dysplasia, early malignancy, stricture. And hiatal hernia is associated with GERD, and we could find hiatal hernia in GERD. Now coming to the reflux monitoring, that is second test of choice. In this, we measure the acid exposure of lower end of esophagus, that is at 5 centimeter from lower esophageal sphincter, and we would measure time exposure of lower end, and it is proportional to the reflux duration, the reflux frequency, and the pH of the gastric contents. And it can either be done by a wireless capsule, that is Bravo capsule, which is very costly, or a catheter based system. The second is impedance study, that is tells about the flow of the content or reflux. Since this measures impedance and not the pH, even non-acidic content would be noticed by this study rather than only acidic pH, and some patients may have non-acidic Gerd, in which this is the test of choice. So this is again the algorithm. Upper GI endoscopy, we do not found. We go to the pH study. If in the pH study is positive, we mention it as non-erosive Gerd, and if it is not there, it is not an acidic Gerd, or it could be a functional heartburn or any other pathology. This is the wireless pH capsule. We endoscopically place a wireless capsule that have a telemetry device we place at the waist of the patient, and it measures the pH up to 96 hours. Since there won't be any catheter in the nose, the patient has less discomfort, and there is ease of interpretation. But in transnasal catheter, a catheter is placed from nose up to the lower end of esophagus, and in this it can usually be done for up to 24 hours only. But it has advantage that impedance can also be measured with it. The Bravo pH capsule is very costly. It costed about 3 lakhs in India recently, and it is not usually done. The most commonly before surgery of Gerd, the study that is usually done is catheter impedance pH study. Now, reflux study, there are few parameters that we would see that we need to see on reflux study. That is acid exposure pH time. If we did a 96-hour study, it should be more than 6%, and the reflex event should be more than 80 hours for diagnosing Gerd. Now, coming to the side effects of PPI therapy, there have been mentioned many side effects of PPI therapy, the most important of which are Clostridium difficile infection, multiple enteric infections including Salmonella, chronic kidney disease, acute interstitial nephritis and chronic interstitial nephritis, dementia, pneumonia, hypomagnesemia, COPD. But all of these are weak associations, and these are not causation, and no study have proved them to be causal factors. These are just associations, and we need high quality study to associate these two infections. The only side effect that has been associated and the causation has been seen is enteric infections, most predominantly Clostridium difficile infection that we see in patients with taking antibiotics. The same is with PPI. Patient on chronic PPI therapy can have Clostridium difficile infection. For patient and for the treatment of Gerd, we as gastroenterologists generally agree that well-established benefits of PPI far outweigh their theoretical risk, and we should not stop the patient on Gerd. So the next is what is the duration of PPI therapy? If we have already discussed that if it is initially responsive, we can switch to we can turn it off, switch it off, or give a tapering dose to a lowest effective dose. And if we did a endoscopy beforehand, and if we see a LAC and LAD esophagitis, the therapy is long-term therapy, and it is usually lifelong. So endoscopy would help in this too. That if there is LAC and LAD esophagitis, we would give a lifelong PPI therapy. Now, de-prescribing PIP, this is the guideline recently published that many of the patients are taking PPI without even indications, and we should support de-prescribing PPI. All patients without a definitive indication for chronic PPI therapy should be considered, and it should be solely based on lack of indication and not because of concern of PPI associated side effects. Tapering, though it is not scientifically proven, and a tapering can be done for over 4 to 8 weeks for reducing reflux hypersecretion syndrome, in which we can give a half dose PPI or an alternate dose PPI for 4 to 8 weeks before stopping the PPI. And the only indication for long-term PPI that is more than 8 weeks or lifelong is Barrett's esophagus, class C and D esophagitis, and esophageal strictures, that is complication of GERD. Now, PPI in special situations, the only PPI that is category C is omeprazole. Rest of the PPI all fall in category B. So we can give any of the PPIs apart from omeprazole. Omeprazole is not preferred. For breastfeeding in females, PPI excretion into breast milk is minimal, and since the PPI we take is enteric coated and it is destroyed by stomach mucosa, but in this it is carried from the breast milk to the fetus, it goes through the stomach and there is no capsule, so it would degrade it. So PPI is definitely safe in breastfeeding individuals, breastfeeding mothers. And drug-drug interactions should be seen. Iron supplement, Iron supplement would not work in patient taking PPI therapy since it would not reduce the iron. CYP metabolism interaction is least with rabeprazole and pantoprazole. Clopidogrel, there are few trials that have said that if the patient is on chronic PPI therapy, the effect of clopidogrel has been reduced, and in these conditions rabeprazole has been considered safe. So if the patient is taking clopidogrel, rabeprazole is rather preferred. And if the patient is on anti-epileptic therapy, which is rather important therapy, the PPI would increase the dose of phenytoin, the concentration of phenytoin. This is the management of GERD in pregnancy. In either of the pregnancy, mild, moderate or severe GERD, the first is lifestyle and dietary modification. The second step, according even to the guidelines, is not starting PPI. The patient should be started on alginates, which have now proven to be safe in PPI, along with in pregnancy, along with antacids. The third step again is not PPI. We can start the patient on sucralfate suspensions that is not systemically absorbed. The next is we can start the patient on H2 receptor antagonist, and ranitidine is not preferred. And the last comes PPI, and the data on PCAB is still not very evident, so we should not start PCABs, that is vonoprazan, and start the patient PPI except omeprazole, that is category C. And even if the patient is asymptomatic, then we should do an upper GI endoscopy. Now, the symptoms are very similar to GERD. We would assume the patient to be a GERD, but the response to therapy is not optimal. That is, we would give them PPI, double dose PPI, switching to all the PPIs, but it would not work. And in these patients, we could suspect if there is associated anxiety, IBS, functional dyspepsia, and other psychosomatic disorders. If we need to confirm that, the upper GI would be normal, the reflux testing acid exposure time would be 6%, and we should do manometry. Since it is not responsive to PPI, it could be another disease. So in these patients, we need to do manometry to rule out other diseases, and we need to rule out all the mimickers. So this is according to the Rome 4 criteria. GERD spectrum, the PPI efficacy is highest in esophagitis, next is NERD, next is reflux, and in functional heartburn, almost the PPI does not work. So what is the difference between reflux hypersensitivity and functional heartburn? In reflux hypersensitivity, as the term is reflux hypersensitivity, the patient's esophageal mucosa is hypersensitive to the reflux. The reflux can be less non-acidic, but non-acidic. The upper GI would be normal, acid exposure time would be 6 seconds. But there is association. If we do a reflux study, there would be an association between physiological reflux that occurs in normal individual and the symptoms. But in functional heartburn, there is no correlation. There would be no reflux. The patient would be complaining of heartburn. If we see the charting on reflux study, even without a physiological reflux or any reflux, the patient would continuously complain of heartburn. But the management of both these studies, both these are similar. The only difference is the role of PPI is more in reflux hypersensitivity, less in functional heartburn. The therapy of choice is cognitive behavior therapy, hypnotherapy could be tried, and the last option is GERD. For pain, the drug of choice for functional chest pain is TCA, SSRI, and SNRI. For any pain, we usually prefer TCA and SNRI. So here we usually use triptomer, that is amitriptyline, but imipramine could be used and venlafaxine could be used. The dose is starting from 10 mg to 50 mg. For hypersensitivity esophagus, the drug of choice is SSRI, though TCA would again work, but it has more of side effects, so we do not use. And for global sensation that we use is the drug of choice is TCA, that is amitriptyline, and we use 25 mg in evening. The behavioral interventions is cognitive behavior therapy. We try to change thoughts, feelings, behaviors related to symptoms. We could try hypnotherapy, and we could also try relaxation strategies to decrease stress and anxiety. So when to consider patients for therapy of GERD? Patients of proven GERD, first the term is proven GERD. The patient should have undergone upper GI, and if it is normal, the patient should have gone reflux testing before referring the patients for endoscoping and endoscopic therapeutic intervention. The patient should have been tried on PPI therapy. The patient should have optimal ongoing symptoms despite optimal PPI therapy. And the patient can be referred if the patient is not agreeing on for long-term PPI therapy and is worried about his side effects that he is taking PPI. And if regurgitation symptoms are predominant, since for regurgitation symptoms, the PPIs are not that effective. The basic principle of surgery is reduction of hiatal hernia. The advantage is that we can, if there is an hiatal hernia, we can reduce that. After reducing, we can wrap the fundus of the stomach that this is the fundus of the stomach, we can wrap it around the upper end of the esophagus. That can be either 360 degree throughout or 270 degrees. That would create a lower esophageal LES competence. This could be either done surgically or endoscopically. These are the comparative diagram. In the most commonly used method is laparoscopic fundoplication, which is the gold standard, in which a reduction of hiatal hernia with crural repair would be done. But the complication is gas bloat, since the pressure could be very high and the patient could not vent out the stomach. That is, even the physiological reflexes would go off. So there would be an inability to bench, and the patient may have gas bloat syndrome. The second is the endoscopic intervention is transoral fundoplication. The same thing, we do it without any incision through the endoscopy. We go into the stomach and create a fundoplication. And the third innovative idea is magnetic sphincter augmentation, which is a necklace-like bead structures that we place laparoscopically, and it increases the LES pressure. And whenever the food bolus comes in, it relaxes. It was invented in Japan. And indications of surgery in hiatal hernia. We see in endoscopy report, we should not straight away refer any patients of hiatal hernia to surgery. Type 1 hiatal hernia, that is most common, that is sliding type, of any size, even if it is very high, more than 5 centimeters, it should only be referred for surgery when the symptoms of GERD are not controlled with medical therapy. And the other indication is type 1 hiatal hernia with bleeding ulceration at fundus region, that is Cameron's ulcer, and if the patient is having recurrent bleeding or recurrent anemia. Now coming to the new drug class, that is potassium competitive acid blocker, that is vonoprazan, that is available in Japan since it's available in Japan since 2015. It has been approved by FDA for esophagitis in last year 2023, and in market it's available since last 3 months, and it is manufactured by a single manufacturer. Versus PPI, it has no relation with food intake, so compliance would not be an issue. It need not to be taken 30 to 60 minutes before. It is not a prodrug, not metabolized by CYP2C19 and CYP3A4, so there would be no interactions at all, and there is longer duration of actions, and there is less nocturnal breakthrough symptoms. So vonoprazan in Gerd, it is not mentioned in the ACG guidelines that was published in 2023, and it was approved in the drug was approved in 23, and though it may come later, and it may work in PPI resistant esophagitis cases. The dosing is 20 mg OD for 8 weeks, followed by maintenance of 10 mg OD. Now coming to baclofen, they have role in GERD? It is a GABA B agonist that increases the LES competence. It helps in regurgitation and belching. A trial at doses of 5 to 20 mg TDS can be considered in patients with objective documentation or of continued symptomatic reflux despite optimal therapy, though trials do not usually recommend that, and drowsiness, sedation and constipation are intolerable symptoms of baclofen. It can be specially tried in patient with belching, gastric belching, that would help. Now role of prokinetics, that usually is an add-on in all the PPIs that we use, domperidone, etopride, levosulpride, but the guidelines mentioned against treating patient with prokinetic of any kind for GERD therapy unless there is objective evidence of gastroparesis. We assume the patient to be a gastroparesis, that is not usually the case, and start the patients on prokinetics. So it should be prohibited and not used, since there are drowsiness, agitation, depression, dystonic reactions, tardive dyskinesia, though etopride does not cause tardive dyskinesia. Along with that, domperidone prolongs QT interval, domperidone and levosulpride, and it should not be used, and levosulpride can have psychiatric side effects since it crosses blood-brain barrier, and it is also an atypical antipsychotic. Role of sucralfate, it is not currently recommended apart from GERD in pregnancy that we have already discussed. It is a mucosal protective agent that forms a layer. Role of alginates and antacids, it is not used for healing of esophagitis and should not be used in esophagitis. It should only be an on-demand symptom relief with little evidence to favor one type over another. The second syndrome we usually see in our OPDs is belching. Belching, the patient would have complaints, multiple burping and belching throughout the day. That could be psychosomatic or physiological. So the belching can be classified into 2 types, that is gastric belching and supragastric belching. The physiological belching is gastric belching, and it can occur up to 30 times per day, and it is involuntary and cannot be stopped. The patient we see in our OPDs are supragastric belching. That is voluntary to start with, and the patients become behavioral of that, and complaints of multiple belches throughout the day, that could be hundreds in a day, starting from 30 to 500s. So in belching, the air that comes out of the mouth is not gastric stomach, and it is not the bloating that it is relieving. The belching is the air comes into the esophagus from the LES. It goes to the lower esophageal sphincter, and again, even without entering the stomach, it comes out, and it causes belching. And the patient gets behavior of it because it relieves an uncomfortable GI sensation. It is voluntary to begin with, becomes out of control. And how can we differentiate that? It doesn't occur during speech, singing. It is lessened with distraction. It doesn't occur during sleep. The patient could have associated psychosomatic complaints that if the patient, now we say that patients, if he's pressed somewhere and if he is touched, she or he belches. The management, the only management is by behavioral therapy, and we can try baclofen with partial relief, and few small trials have been there. The best management is diaphragmatic breathing, in which the patient is advised to lie down on comfortably on a bed and put his hands on stomach, and the patient should be asked to take the breath by stomach rather than by mouth. She should lie down for 2 minutes, putting her hands on her stomach, and try to breathe in, expand the stomach, and try to breathe out, lower down the stomach, and it should be done 30 seconds throughout the three times daily, and it would decrease the amount of air that is entering into the esophagus, and she is getting used of. Now coming briefly to dyspepsia, it is different from GERD. It is any discomfort for more than 4 weeks. The room for definition, the symptoms are different. It is epigastric pain, postprandial fullness, early satiety, and epigastric burning. And there should be no structural disease to explain the symptoms. The mimickers of dyspepsia are again different from GERD. It could be peptic ulcer disease, that is gastric or duodenal ulcer, Helicobacter pylori. The patient could have biliary disease or a gallstone disease that could be present as dyspepsia. Pancreatitis, any heart event can again present as epigastric pain, pancreatitis, gastric paresis, abdominal wall pain that could be differentiated by examination, celiac disease or carbohydrate malabsorption, and rarely stomach infiltrative disease such as malignancy or amyloidosis, or even patients with GERD may complain of predominant epigastric discomfort. The alarm signs of dyspepsia are more than 55 years, weight loss, anemia, GI bleed, dysphagia, persistent vomiting, GI, family history of GI cancer in first degree relative, and NSAID use. And for any patient with dyspepsia, we should look out for these signs, that is pallor, icterus, cervical lymph nodes, supraclavicular lymph nodes, and axillary lymph nodes, any hepatosplenomegaly if it is present, and skin lesions that could be a marker of malignancy or any systemic disease. So when should we do endoscopy in dyspepsia? Either the patient is 55 years of age and has new onset dyspepsia, and if it is less than 55 years of age and he has these alarm symptoms. Now every patient, now the guidelines recommend that every patient of dyspepsia should undergo H. pylori testing, though the guidelines recommend stool antigen test and urea breath test rather than endoscopy and rapid urease test. But it is mentioned because the cost of endoscopy, RUT test is RUT and endoscopy is very high in Western states. The confirmation of eradication should be done 4 weeks after completion of H. pylori eradication therapy rather than just after completion of therapy. But we have seen that many patients with dyspepsia with H. pylori treated, they do not respond. So the next therapy is anti-secretory trial, and trial of 4 to 8 weeks similar to GERD is done, and the response rate is around 73%. So it's the same algorithm for dyspepsia: less than 60 years, more than 60 years, more than 60 years, straight away endoscopy, less than 60 years with alarm symptoms, and after ruling out all the mimickers, doing an ultrasonography, routine tests and ECG, we can mention if it is an organic disease is present, we can treat that, and if it is not present, we can label as dyspepsia. But dyspepsia can either be of two syndromes. It can be postprandial distress syndrome, in which the patient complains of bloating and abdominal discomfort after eating food that occurs usually within 15 minutes, or it can be an epigastric pain syndrome that is unrelated to food intake. But in either of the cases, if it is functional dyspepsia, we should do an HP test, and preferably by non-invasive tests such as stool antigen test. And after that, if it is not working, in postprandial distress syndrome, the next line of therapy is adding a prokinetic, which was not there in GERD, and it is not there in PU, peptic ulcer disease, neither in epigastric pain syndrome. And after if the prokinetic is not working, we can add an acosiamide, that is fundal relaxation agent. In epigastric pain syndrome, we can give PPI, and after PPI there is no role of prokinetic, no role of acosiamide. We straight away move to tricyclic antidepressants, that is amitriptyline.
Excellent and thorough presentation. You have highlighted the key aspects of diagnosis, red flags, and management strategies that are very critical in our practice. The clarity with which you address the complexities of acid peptic disorder and Gerd will certainly help us in all providing more effective care to our patients. We'll be conducting a quiz contest on the topic that Dr. Gupta has just covered. So this will help reinforce what we have learned and provide an opportunity for some fun and interactive engagement.
Question number 1 is what is the amount of normal air contained in stomach? The first option is 5 to 10 ml, 100 to 200 ml, 250 to 500 ml, and 500 to 700.
You have to raise your hand first. First raise your hand. Sir, you have to select who have to answer.
Dr. Mari.
Your answer is?
B.
So you just say, is it right?
Yeah, it's right. B.
Wow, क्या बात है. ठीक है. Next.
For a patient with GRD, which lying position will have maximum nighttime reflux and symptoms?
Left side. B.
Elevated left head position.
You have to raise your hand.
Right side.
I want that newcomer should be given some preference. Because just backbenches.
Please raise your hand. Sir will select from this side.
Dr. Madhu.
Newcomer क्या है?
Newcomer को आए नहीं तो क्या है?
There are not many backbenches.
Done.
Done.
B is not the right answer. So we'll move to the
Dr. Anju.
B is not the right
Not the right
answer.
answer.
Dr. Meenakshi, your answer will not be accepted.
It is max. नहीं वो कुछ नहीं.
The right answer is C. Make a plot for Dr. Sachidanand.
Examiners will not given.
The third question is, you just listen to whole question and options, then raise your hand and stand on your side and then answer, right? For which patient, which classic Gerd symptom would you advise for endoscopy before PPI trial? In every patient, in patients with dysphagia, in patients with cardiac disease, in patients with anxiety and stress. First raise your hand, first raise your hand. Raise your hand.
Patient with dysphagia.
Sir, please stand up.
Patient with dysphagia.
Patients with dysphagia. Is it the right
Correct,
answer? A big applause for sir. So we'll take the next answer from this row.
This. Okay.
Fourth question is young boy with history of atopy presents with chest pain, mild burning and dysphagia. What would you do next? Start PPI trial and follow? Endoscopy with biopsy from esophagus, manometry, or start with neuromodulators? First raise your hand.
पहले मैनोमेट्री क्या होती है बता दीजिए.
सर ऑप्शन करा.
Sir, please. Sir. So the answer is that start PPI trial and follow?
The answer would be B since dysphagia is present, so it is in red flag sign. So B.
So we have to give more.
Okay, no, sir.
So the correct answer is endoscopy with biopsy
Or
from
question is-
esophagus.
Eosinophilic esophagitis.
B option is the right
मैनोमेट्री
answer.
बता दीजिए क्या है.
So
Manometry.
manometry में सर esophageal
To diagnose eosinophilic esophagitis.
manometry. No,
That B.
B, no, so since we have red flag sign, that is the patient is having dysphagia. Even if it was a typical classical patient, but if the patient has dysphagia, we would go for endoscopy. But in this patient, there are many red flags. The patient is young boy with history of atopy, with chest pain that is not a typical GERD, and so we would go an endoscopy with biopsy. Not eosinophilic esophagitis. Manometry is a study which is a catheter-based study in which multiple catheters are placed through. Catheter is placed. Catheter are placed from the nose to the esophagus. One catheter with multiple sensors in it at every level, and it can detect the pressures in multiple levels. And we could get a finding graph that would measure the pressures. And it is usually done for esophageal motility disorder, that is achalasia. Motility disorder. Sir, I have not started it yet, but we are planning to start it, sir.
Okay. So we'll move to the next question, and once the answer is getting we are from the audience, then we'll only discuss. So question 5 is, according to evidence, which practice is most important in preventing GERD symptoms? Avoid alcohol, select decaffeinated beverages, avoid citrus fruits, lose weight. You have to
जो आंसर दे चुके हैं वो ना
most important.
Answer, please, up करो. So your answer is lose weight? No, there is no such option. So you have to select one. You have to select one. B. Most important in preventing GERD symptom. Sir, please. Avoid citrus fruits. So is that the right answer? No, this is not the right answer. Next option, Dr. Agrawal. D. Lose weight. Is it the right answer?
Yes.
That is the right answer. A big applause for Dr. Agrawal, sir. नहीं सर बहुत देखे इसको वो बोलता हूँ बैक हमने इस बार बैक बेंचर्स को सर थोड़ा सा
इनको सर बैक बेंचर्स और जो लोग रेगुलर में आते थे उनको मौका मिल गया है. Now
we have 4 topics.
Question and answer rounds first.
Yeah, answer and question.
पहले को question answer हो गया 5 questions.
So now the session is open for the question and answer. हाँ सर आपकी क्वेश्चन है. Shankar ji.
But most of the practitioners even today we start with antacids and alginates. Earlier antacids were not much effective and they usually cause constipation that is also present in pregnancy since it contains calcium. The alginates are very much effective in providing symptomatic relief. So the first line would always be alginates and antacids followed by sucralfate, which is not rather effective. First is then we should start a trial on famotidine or H2RA, that is famotidine, then PPI. The PPI should not be started first. Even though they are effective, safe, they are category B, but why to take a risk in, especially in first trimester pregnancy?
Okay.
In the slide,
alcoholic has a weak relation.
It is a weak relation. Even it should not be recommended. According to the guidelines, it should not be recommended. So it is weight loss is the highest side. No, most important effect.
Weight is most important.
My own question. It's a very nice time that you have the gastro along with the cardiology class on the guys. So my question is that, Dr. Rishabh, would you suggest us, so many people of our colleagues and seniors, what are the tips you are giving for the hard one? The people they in the nocturnal hard one, you know, the people they are very suspicious of मुझे ischemia तो नहीं हो गया है. So how you practical tips please you give both of you? How to differentiate that is the heart problem or is the ABD?
So the
First I'll proceed.
yes, sir.
Any patient who is having risk factors on background, if the patient is diabetic, hypertensive, dyslipidemic, obese, and any nocturnal chest pain may be a sign of very severe critical narrowing of coronary artery disease. So in background of risk factor, you have to look at the nocturnal chest pain, postprandial chest pain, nocturnal chest pain. These are the grave indicator of critical stenosis of the arteries. But if the patient is having no risk factors, no these risk factors, and if the heartburn is associated with different meals, if heavy fatty meals, if they have taken that, they may be considered as a heartburn. Right?
Because I want to ask, the risk factors, as you said, is very common for all doctors who are sitting over here. Everybody having the risk factors like the AIDS, like the hypertension and diabetes. So I wanted to know from out of you, So what is the practically you should say, recommend that how to differentiate in this heartburn, in the nocturnal heartburn, that is the ischemic or not. What one should do in the night, it happens to somebody.
Yeah,
So
definitely.
risk factor, you said everybody is having that risk factor. That is the common problem of the society, even more in the doctors group. So you suggest with the practical tips. रात में 2 बजे मान लो किसी को पूछने हमारे डॉक्टर के कपूर साहब ने जो he was a professor and head and professor in PRD Medical College. He died in the night. It happens. I think most of our senior people must be knowing about this thing. सीने में दर्द हो रहा साहब, कुछ खा लिया, दवा पीपीआई ले लिया, कुछ ले लिया, थोड़ा सा रिलीफ हुआ, फिर सो गए, फिर दोबारा हुआ, कुछ कर नहीं पाए, वो चले गए जो है। ऐसी सिचुएशन में जो है, तो आप प्लीज गाइड
बिल्कुल सही बात है।
सबसे इम्पोर्टेंट बात ये है कि आपको
Stress.
करना चाहिए।
एक्सक्लूड
करेक्ट करना चाहिए। फर्स्ट रेफर टू करेक्ट। पहला अगर शॉर्ट हिस्ट्री ऑफ हार्ट पेन,
अगर आपको
फर्स्ट टाइम शॉर्ट हिस्ट्री, हाँ सब पहला टाइम तो ईसीजी भेजना है, मल्टीपल एपिसोड्स है, रिस्पॉन्डिंग टू पीपीआई है, आपको नॉक्टर्नल बर्न्स हो रहा है तो फिर कर सकते हैं। हाँ बट फर्स्ट पेन नेवर इन लाइफ टाइम सिवियर।
Most of our doctors are above 45 years, 40 years of age. Always think of cardiac first.
बिल्कुल क्योंकि गैस की डायग्नोसिस तो पेशेंट खुद ही बना लेता है कि गैस है, बट एज अ डॉक्टर वी शुड नॉट इग्नोर एनी नॉक्टर्नल साइन इफ इट्स अकरिंग फॉर द फर्स्ट few days or few times.
Nocturnal sign means you are sitting in your clinic.
सर गैस की खाने के बाद अगर वो किसी को बता रहा है तो मतलब वो हार्टबर्न नहीं है।
If you are sitting in your clinic, if you have some stress,
गर्ड है या क्या है, कैसे गर्ड की सिम्टम्स कैसे आपने पूछे?
most of our doctor colleagues are suffering either from diabetes or hypertension. Never neglect these symptoms and get it investigated fast as early as possible. Because first ECG may be normal, second ECG may be abnormal, and even first and second ECG may be normal, but the third ECG may be abnormal. Always get TMT done, echo done, and if needed, angiography done. We should not, because most of our doctors are hesitant about getting angiography done, and we have few of, I will not name few of our doctors who have just neglected those symptoms, and when the angiography was done, found double vessel or triple vessel disease. So never neglect this thing. I have taken PTI and I have become online.
नहीं, नॉक्टर्नल सिम्टम्स के लिए तो थ्रेशोल्ड अपना कम रखना पड़ेगा।
For all my friends and seniors, I want to get the recommendation from both of them that doctors should go of my age or maybe my juniors, maybe 50, 60 years of age. I need a recommendation from both of you because you are in the CT cardiologist and the gastroenterologist that please go for the cardiac checkup for all the doctors routinely, maybe in 6 months, maybe in that. So तुम्हारी तरफ से recommendation हम सब के लिए आना चाहिए।
हाँ 100% सर।
थैंक यू, एक्सेलेंट डॉक्टर सर, कॉन्ग्रेचुलेशंस। एक जनरल कंसेप्ट है कि मिल्क पेप्टिक अल्सर सिंड्रोम में फायदा देता है, दूसरी तरफ मिल्क में प्रोटीन है, कैल्शियम है, जो कि एसिड स्टिमुलेशन करता है, तो क्या रियल फैक्ट क्या है?
सर पेप्टिक अल्सर सिंड्रोम है जिसमें अल्सर्स हैं, गैस्ट्रिक अल्सर, ड्यूरनल अल्सर। यूजुअली कोई भी अगर कोल्ड चीज़ लेंगे या फूड लेंगे तो गैस्ट्रिक अल्सर पेशेंट में सिम्टोमेटिक रिलीफ मिलेगा, पर बेसिक पर्पस पेप्टिक अल्सर सिंड्रोम में हम लोग का टारगेट है हीलिंग, म्यूकोजल हीलिंग करना। उसमें मिल्क या कोई भी प्रोडक्ट हेल्प नहीं करने वाला है हम लोग को। सिम्टोमेटिक रिलीफ जस्ट लाइक एंटासिड मिल्क काम कर रहा है हम लोग का, पर अल्टीमेट लाइन ऑफ ट्रीटमेंट नहीं है वो। तो पेशेंट कैन
इमीडिएट ट्रीटमेंट में कोई फायदा नहीं, मिल्क देना,
सिम्टोमेटिक रिलीफ, ठंडा दूध से सिम्टोमेटिक रिलीफ मिल जाएगा पेशेंट को। हाँ ठंडा दूध पीने साहब उससे पिला था तो पार्शियल।
दूसरा एक जनरल बिलीफ है कि लॉन्ग टर्म जैसे सालों पेशेंट पीपीआई खाते हैं तो उसमें आयरन एब्जॉर्प्शन कम हो जाता है, एनीमिया होता है, इस पर आप क्या टिप है?
सर लॉन्ग टर्म इसीलिए सर गाइडलाइंस आई थी कि अगर किसी को भी लॉन्ग टर्म पीपीआई चलना है तो उन लोगों को देखना है कि क्यों पेशेंट स्टार्ट किया, क्योंकि कोई भी फिजिशियन डरता है स्टॉप करने से, क्योंकि स्टॉप करने के बाद पेशेंट का रिफ्लक्स हाइपर एसिडिटी होता है। सर तो पहले तो स्टार्ट देखना है कि क्यों स्टार्ट किया गया था पेशेंट को पीपीआई, कोई इसोफेजाइटिस क्लासी नहीं थी, पेप्टिक स्ट्रक्चर नहीं था। अगर कोई भी स्ट्रॉन्ग इंडिकेशन नहीं मिलता है हम लोग को पीपीआई उसका, तो हम लोग टेपर डाउन करके ये तो स्टॉप कर सकते हैं। या कोल्ड टर्की बिल्कुल स्ट्रेट अवे, या तो फिर टेपर डाउन करना है पेशेंट को 4 to 8 वीक्स तक ऑल्टरनेट PPI देके, एंड आफ्टर दैट इफ देर आर symptoms we can give the patient on demand PPI for that rather than giving PPI for so long.
आयरन डेफिशिएंसी PPI के एडवर्स इफेक्ट में
आता है, हाँ सर, PPI के कंप्लाइंस है सब आयरन डेफिशिएंसी ड्रग सर, यही आयरन डेफिशिएंसी, सी डिफ इन्फेक्शन और मल्टीपल एंट्रिक इन्फेक्शंस, ये 3 प्रूवन है, मतलब होता है सर उसमें. गो फॉर
Lifestyle.
So for lifestyle modification in GRD, the most important ones are to stop smoking if the patient is smoking and to lose weight, and there is proportionately decreased symptoms with losing weight.
Nothing related to the.
Apart from that, yes, apart from that, we should try avoid taking acid content such as citrus, मौसमी संतरा नहीं लेना है, citrus fruits नहीं लेना है पेशेंट को. Alcoholic beverages की frequency कम करनी है, और frequency नहीं कम कर सकते तो the amount should be decreased. And the patient should advise to lie down after 2 to 3 hours. Recommended is 3 hours. If the patient is having symptom of GRD, 3 hours after any oral intake, the patient should lie down, not before that, 3 hours. And the patient can use a wedge pillow for nocturnal symptoms. If the patient is having propped up position में रहना है, so wedge pillow आजकल available है, उसको use कर सकता है.
समाज में तो ऐसा है जो लोग अपना PPI खाते रहते हैं, डॉक्टर को दिखाते ही नहीं. तो 3 साल से यही खा रहे हैं, 4 साल से खा रहे हैं, कहते हैं.
Side effects of long-term PPI.
So the iron deficiency anemia, C. diff, Clostridium difficile infection, Clostridium difficile infection. So it is a infection colitis that usually presents with long-term chronic watery diarrhea, and it is usually present in patients taking long-term antibiotics, but it has not been seen that it can present in patients taking long-term PPI. And multiple enteric infections, especially in pediatric patients, that can be any infection, since the gastric acid would digest the bacteria that we are intaking, and it would not be destroyed, so it can increase the risk. Apart from that, the PPI can be used in patients with CKD, AKI in any patients, though there is some risk of AI in interstitial nephritis.
How much this H. pylori infection is common in our population?
Sir, in Indian population, it is 85 to 90% is prevalent.
Very common.
Very common. So even in asymptomatic patients, we do an endoscopy, we do an RUT, it would come out positive. But since H. pylori is a proven carcinogenic agent, we should treat if there ain't any symptoms and we get a report of H. pylori positive, we should straight away treat that patient.
Because this H. pylori infection is...
It can lead to gastric carcinoma. It is a risk factor for gastric.
No, is there any breath test for H. pylori?
Yes, sir. For the recommended test for H. pylori testing is not endoscopy and RUT. The recommended test is urea breath test and stool antigen test that are very sensitive and specific. But for follow-up, and the serological testing should not be done. Since serological testing would be present if the patient has been eradicated, again the IgG would be positive, IgM would be positive. The third test of choice is endoscopy and rapid urease testing. The fourth is endoscopy and biopsy, the biopsy that we see in histopathology slides.
So how do you treat H. pylori infection?
So the treatment of choice is H. pylori kit that should be given for at least 10 days, 10 to 14 days, and it contains 2 antibiotics usually and a single double dose PPI. The 2 antibiotics we use commonly are amoxicillin 750 milligrams twice a day and clarithromycin 500 milligrams BD. Clarithromycin. H. pylori kit. Apart from that,
How long this cycle?
14 days. 14 days. 14 days.
And then role of this acronitazole?
Yes, sir. The resistance of clarithromycin is increasing in our population since we are using most of azithro, and if in a population it is more than 15%, the clarithromycin based regimen should not be used. So in that patients we use a levofloxacin based regimen that contains amoxicillin, levofloxacin and double dose PPI. Apart from that, there are multiple regimens. The one you are mentioning is the metronidazole containing regimen that contains bismuth, metronidazole, amoxicillin and levofloxacin.
Metronidazole for how
For
many days?
14 days. It is a BID dosing, 250 BID.
Any role of prebiotics?
There is no proven role, but there are some lactobacillus reuteri probiotics are present that has a non-specific role in augmenting the role of these H. pylori kit.
Thank you.
Is there any role of levosulfide? These days, combination drugs are coming. Levosulfide.
So levosulfide is basically used in patients with gastroparesis. The prokinetics as a whole group are used in patients with gastroparesis, and levosulfide is more effective than domperidone and metoclopramide. But it crosses blood-brain barrier. It is also atypical antipsychotic agents. So it is not preferable in any guidelines to use levosulpiride.
For long term.
For long term, yeah, and even
for short term.
and even if any prokinetics, the recommendation are it to use not more than 4 to 8 weeks. But we do see patients taking domperidone lifelong and having many side effects, such as galactorrhea and extrapyramidal side effects, everything else.
Why H. pylori kit is not so popular?
So among gastroenterologists, is the most popular drug we use. Kit is used, but before starting H. pylori kit, there should be an objective evidence for starting it. And many patients do not get an endoscopy done, so we do not use them empirically.
What is
Paracetamol.
most of the time?
Not omeprazole, except omeprazole you can.
Analgesics,
right?
analgesic push.
Analgesic. Acha.
Most of the time, people are having gas trouble in Gorakhpur area. What is the comment of it? In spite of having metronidazole, tinidazole every month and every. This is one question. Second question is only bismuthal along with tinidazole or only bismuthal alone?
Bismuthal, the bismuthal containing regimen is quadruple regimen. We have 4 drugs along with bismuth. And for the first question, in our population, the patients are usually not responsive to PPI and not responsive to HP kit. So the patients are usually of functional and psychosomatic disorders that we see that is not responsive to PPI.
No, it's not functional because what we have seen with even after repeated stool examination, you give one dose, complete one dose, after 3 months or so, they will again have the same heavily platelets. So what is the reason in this area? What is the cause?
The cause of GRD.
Something to do with the water here.
The contamination, the H. pylori, the prevalence of H. pylori is higher in India because of contamination and poor hygiene. So definitely hygiene plays a role in spreading of H. pylori infection.
Just a few words about eosinophilic esophagitis. How do you diagnose? Most of the time we see in CBC that eosinophils are raised, patient is having not many acid peptic disorder kind of symptoms. So how do you approach, when do you diagnose and how do you treat? Just few words.
The first thing to diagnose is to suspect a patient with eosinophilic esophagitis. If any atypical findings of Gerd is present and if there is any dysphagia, any evidence of impaction of food in children, we should get an endoscopy. There are several findings in endoscopy that suggest endoscopic eosinophilic esophagitis. But definite diagnosis is to take multiple biopsies, and the biopsy should be taken when the patient is not taking PPI for last 7 to 14 days. So we should get in multiple biopsies.
Is it more common in children?
Yeah, it is more common in children, more common in patients with atopy and eosinophilia.
Okay.
Just now, it was a wonderful lecture, Dr. Rishabh. देख ही सकते हैं इतना ज़्यादा डिस्कशन और इतने लोग आए हैं यार. This was, I think, one of the record lectures में इतने members आए हैं यार. And it is a very good thing. And it was a topic of great interest for everyone, I think. And now I think everyone is receiving calls from their clinics. So let's wind up the session.